Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 167 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the next question reads, ATG, a 24-year-old male university student presents to your travel medicine clinic 7 months before departing on a planned mission trip to a Kenyan slum with questions about preventing hepatitis A virus, abbreviated as HIV infection. He has no known drug or food allergies. He has no significant past medical history. So my question to you is, which of the following would be the best recommendation for prevention of HIV infection in ATG's case? Would it be A. Administer immunoglobulin 0.02 ml per kilogram within 14 days of returning from the trip, or B. Administer inactivated HIV vaccine VAQTA 1 ml that is 50 units today and again 7 to 14 days before the trip, or C. Administer inactivated HIV vaccine VAQTA 1 ml that is 50 units today and immunoglobulin 0.02 ml per kilogram within 14 days of returning from the trip, or D. Counsel on common risk factors and avoidance. HIV vaccine is not indicated. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Administer inactivated HIV vaccine VAQTA 1 ml that is 50 units today and again 7 to 14 days before the trip. Administering the HIV vaccine now and again in 6 months is correct. This is the CDC's recommended dosing for travel to areas of high NBME. The first dose should be administered as soon as possible after travel is expected and should be administered at least 2 to 4 weeks before departure. Passive immunization from administration of immunoglobulin can be considered in infants, children younger than 1 year, and adults who are departing in less than 2 weeks. That makes answer A incorrect. Immunoglobulin would not be routinely administered after travel to areas of high endemicity. That makes answer C incorrect. Hepatitis A is transmitted by contaminated food and water in slums in countries like Kenya, where access to clean water may be limited. That makes answer D incorrect. Please advance to the next slide. And the next question reads, AJO, a 65-year-old male patient is admitted for observation and treatment after acutely developing fever, jaundice, and itching. With regard to his social history, he denies taking alcohol, smoking, and IV drug use. His pertinent labs include AST of 750 international units per liter, ALT of 800 international units per liter, total bilirubin 7.5 mg per deciliter, anti-HCV negative, hepatitis B surface antigen HB-SAG. Positive, hepatitis B surface antibody, anti-HBs. Positive, immunoglobulin IgM hepatitis B core antibody anti-HBC positive, IgM anti-HAV negative, and HIV negative. So my question to you is, which of the following would be the most likely diagnosis, given the available data? Would it be A. chronic hepatitis C virus HCV infection, or B. chronic HBV infection, or C. acute hepatitis B HBV infection, or would it be D. acute HAV infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. acute hepatitis B HBV infection. A positive IgM anti-HBC, elevated AST or ALT or total bilirubin, and acute symptoms point to a recent HBV infection. That makes answer C correct. Both HBsAg and anti-BS are often positive in chronic HBV, that makes answer B incorrect, but the IgM anti-HBC distinguishes acute from chronic infection. In addition, aminotransferases are usually less than 100 international units per milliliter in chronic infection. That makes answer D incorrect because the anti-HAV test is negative, indicating no acute HAV exposure. The anti-HCV test is negative, indicating this patient has never been exposed to HCV, which makes answer A incorrect. Please advance to the next question. And the next question reads, which of the following is the most common adverse effect of ribavirin? Is it A. thrombocytopenia, or B. hemolytic anemia, or C. depression, or would it be D. anorectal discomfort? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. hemolytic anemia. Hemolytic anemia is a common adverse effect of ribavirin requiring routine monitoring of hemoglobin and hematocrit. That makes answer B correct. Anorectal discomfort is an adverse effect of telaprevir, an HCV-NS3/4 protease inhibitor that was withdrawn from the U.S. market. That makes answer D incorrect. Depression, suicidal ideation, and other psychiatric disorders can be caused or exacerbated by pegylated interferon therapy. That makes answer C incorrect. Likewise, thrombocytopenia is an adverse effect associated with PEG interferon and ribavirin when used in combination. Thrombocytopenia is rare, 0% to 2%, in patients who receive ribavirin in combination with directly acting antiviral therapy, which makes answer A is incorrect. Please advance to the next question. And the next question reads, which of the regimens listed below would be the most appropriate regimen for a treatment-naive patient with HCV genotype 1b monoinfection and compensated cirrhosis? Would it be A. Ombetasvir plus paritaprevir plus ritonavir and dasubiavir for 24-week, or B. Ledipasvir plus sofosbuvir for 24 weeks, or C. Elbasvir plus grazoprevir for 12 weeks, or would it be D. Daclatasvir plus sofosbuvir plus pegylated interferon for 12 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Elbasvir plus Grazoprevir for 12 weeks. Elbasvir plus Grazoprevir for 12 weeks is best. That makes answer C correct. In one clinical trial, CEDGE, the overall SVR was 99% in treatment-naive patients with genotype 1b, including in those with cirrhosis 22% and without cirrhosis 88%. Answer D is incorrect because pegylated interferon regimens are no longer recommended for HCV infections, given serious adverse effects and lower efficacy compared with DAA regimens. Ledipasvir plus sofosbuvir is recommended for genotype 1b infection, however, the recommended treatment duration is 12 weeks. That makes answer B incorrect. Ombetasvir plus Paritoprevir plus Ritonavir and Dasabuvir is a recommended regimen with high SVR for genotype 1b, but the treatment duration is limited to 12 weeks. That makes answer A incorrect. For treatment-naive, genotype 1a/1b patients with compensated cirrhosis, the treatment duration for all recommended regimens is 12 weeks. Please progress to the next question. And the next question reads, which drug and adverse effect pair listed below is the most accurately matched? Is it A. Ledipasvir and vision disturbances, or B. Sofosbuvir and neutropenia, or C. Peginterferon and depression, or is it D. Elbasvir plus Grazoprevir and renal impairment? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Peginterferon and depression. Peginterferon alpha is associated with an increased risk of psychiatric disorders, including depression and suicidal ideation. That makes answer C correct. Serious adverse effects, such as depression, are a primary reason why pegylated interferon is no longer included as a recommended regimen for treatment of chronic HCV. Elbasvir plus Grazoprevir does not cause renal impairment. That makes answer D incorrect. However, a niche for this drug is in the treatment of patients with impaired renal impairment, with a creatinine clearance of less than 30 ml per minute per 1.73 meters squared. Sofosbuvir does not increase the risk of neutropenia. That makes answer B incorrect. Ledipasvir is not associated with changes in vision or color perception, which makes answer A incorrect. Please advance to the next question. And the next question reads, which of the descriptions listed below best depicts the patient at highest risk of chronic hepatitis E virus (HEV) infection? Is it A. a 44-year-old female patient with hepatitis B envelope antigen (HBeAg) positive chronic HBV infection, or B. a 54-year-old male patient with diabetes mellitus with a hemoglobin A1C of 7.0, or C. a 34-year-old male liver transplant patient receiving tacrolimus and mycophenolate mofetil, or is it D. a 60-year-old female patient with chronic HCV infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. a 34-year-old male liver transplant patient receiving tacrolimus and mycophenolate mofetil. Chronic HEV is uncommon in the United States but is thought to be the most common cause of acute hepatitis worldwide. Although it usually causes a short-term, acute infection, patients who are chronically immunosuppressed who are exposed to HEV can develop a chronic infection. That makes answer C correct. There is no association between HEV infection and chronic HCV. That makes answer D incorrect. Or diabetes mellitus. That makes answer B incorrect. Hepatitis D infection, not HEV, is a co-infection with chronic HBV, which makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 168.